Good morning. My name is Lindsay Shaw, and I am joined by Deepa Saboo, Krishna Patel, and Jennifer Estrada. We are ready to begin. Today, we will be presenting our value-based competition plan for Boston Children's Hospital. We are tasked with addressing BCH's rising healthcare cost, unprofitable pricing methods, and process inefficiencies. Since it is imperative to first know BCH's accurate cost prior to the implementation of a new payment method, we utilized time-driven, activity-based costing approach. We then developed our recommendations for the implementation of both a bundled payment method and a physician bonus model in order to address these issues. We are certain that with these implementations, Boston Children's Hospital will be able to further distinguish itself within the Massachusetts market. Let's first begin by examining BCH's current financial position. Historically, the organization has reported higher costs than those of its competitors due to the fact that it treats 90% of the most critical and complex pediatric cases in Massachusetts. Also, since 30% of its patients are covered by Medicaid, and BCH typically receives lower payments for this segment of the patient population, this only further worsens the financial issues. As a result, patients are seeking care elsewhere. BCH has lost its Medicaid contract with the state of New Hampshire and been forced to renegotiate its contract with Blue Cross Blue Shield of Massachusetts. As part of its renegotiations with Blue Cross Blue Shield of Massachusetts, BCH entered into a 3-year alternative quality contract. The graph above, go back 2 slides, please. The graph above depicts the cost advantages for adopting an AQC. The blue line represents the medical expense trend for organizations currently enrolled in an AQC, while the red line represents organizations not enrolled in an AQC. As is demonstrated, by enrolling in an AQC, the organization experiences a greater decrease of medical expenses over the course of 5 years when compared to organizations not enrolled in an AQC. Since the AQC is founded on a shift towards global bundled payment, this was a very important existing contract when developing our recommendation that BCH should implement the bundled payment method. In addition to the AQC cost savings, there are many stated advantages of the bundled payment method over both historical capitation and fee-for-service. Although fee-for-service does not include any bundling, the bundled payment method budgets payments for specific treatments, specific health events, or chronic condition. Furthermore, unlike fee-for-service, the bundled payment method includes performance measures that drive physicians towards efficiency and quality instead of simply volume. Another stated advantage is that both the provider and the payer share in the financial risk, which is not seen in either historical capitation or fee-for-service. Because of these stated advantages, we propose that BCH implement the bundled payment method in order to contain their rising costs. My team and I also propose a 3-step implementation plan for the bundled payment method at BCH. During the first phase, payments would be bundled for acute care, and examples of these would be a clubfoot cast, a femur fracture, or a radius fracture. During the second phase, payments would be bundled for both acute care and post-acute care, covering examples such as appendicitis or hypoglycemia. And finally, during the last phase, payments would be bundled for post-acute care or chronic conditions, such as type 1 diabetes or lupus. I want to point out that the third phase is seen as a long-term vision for Boston Children's Hospital as they progress towards population health. Deepa will now explain the various cost analyses and how TDABC really, in fact, fit into our bundled payment method.
Thanks, Lindsay. Today I'll be discussing the cost analysis methods that were introduced in the case. We've broken them down into 3 sections by RCC, RVU, and TDABC. RCC is a basic proportion of cost to charges. Likewise, RVU is relative value unit, which is based off of the resources used to produce a service line. TDABC, on the other hand, is a bottom-up costing approach which takes into account the time used for a service. Some of the benefits of TDABC would be that it allows us to easily identify any problems within our service line, break down our costs, and allow our charges to truly reflect our true costs. Some of the disadvantages to TDABC would be that it does require an extensive amount of time and resources from the hospital and requires that our costs truly reflect the procedures that we're providing. When we're looking at accuracy, we believe that TDABC is the best form to implement at BCH. This is the Department of Plastic and Oral Surgery. We've developed a worksheet and we've broken it down into 3 different sections. The first section is the personnel process time, and then we've calculated the capacity cost rate for each personnel. Multiplying these 2 figures together, we're able to determine our total cost. The second table is broken down by different procedures, and I'd like to focus on the highlighted sections in yellow, which are our TDABC profit and our RCC profit. Paying attention to the craniosynostosis procedure, which is the last one on the second table, we see a $69 loss under TDABC and a $14 profit through RCC. And the reason for this is because costs are recognized differently under these 2 methods. TDABC takes into account the time and the complexity of the procedure, unlike RCC. If we pay attention to the RCC profits, they're the same regardless of the type of procedure. The next example we have is through the Department of Orthopaedic Surgery. The worksheet is constructed in the same way, and we're able to calculate the total costs. And the TDABC profit and RVU profits are highlighted in yellow. I'd like to focus on the clubfoot cast hospital full cycle procedure. Here we can see that there's $1.50 in profit under TDABC, unlike RVU, which recognizes over $457 in profit. And the reason for this, once again, is because costs are recognized differently. TDABC takes into account that the full cycle is an extremely complicated procedure, therefore there's a higher rate for the cost. Unlike RVU, which doesn't take into account the time and also the complexity level of the procedure. Some of the impacts of TDABC that would be placed upon BCH would be that it allows us to prepare more accurate and fair pricing models. One of our recommendations would be that the prices be reflected on acuity. Therefore, procedures that are less time intensive and complicated should be charged less, and vice versa. Some of the benefits would be that it allows us to negotiate better bundle payments with our payers and identify any profit margin and losses within our service lines. A key point I'd like to make is that BCH is the only hospital in Massachusetts that's implemented TDABC. So this allows us to strategically position ourselves to say that we're providing cost-effective and quality-driven healthcare. Now I'll be passing it off to Krishna.
Thank you, Deepa. Now I will be discussing the key issues that BCH is facing, the recommendations that my team has come up with to deal with these issues, and the outcomes that BCH will face having implemented these recommendations. As discussed by Lindsay and Deepa, bundle payment and TDABC will help BCH to reduce the cost, and it will help BCH to develop a more accurate and acuity-sensitive cost data. As you can see, the third key issue is process inefficiency. Here we recommend BCH to implement SCAMS. So what is SCAMS? It is a standardized clinical assessment and management plans. The main aim of SCAM is to reduce variation in the entire patient care cycle and improve healthcare delivery. SCAMS will help BCH in mainly 3 manners. First, it will help BCH to determine how effective their current clinical processes are. Second, it will reduce the waste. And third, it will help to improve processes. Some of the examples of process improvement are to reduce waiting time and quick turnover rate of beds. Putting all the recommendations together for first, second, and third, that is containing cost, accurate costing, and process improvement will help BCH to deal with the fourth key issue, that is patient attrition, where BCH is losing its patient to their competitors. So having implemented these recommendations, BCH will be able to better utilize its resources, it will be able to improve its revenue, and it will be also able to expand its patient market. Now I will invite Jennifer to discuss physician bonus model. Thank you.
Thank you, Krishna. We will now be discussing the physician bonus model, and afterwards I will be addressing the value added to the patient. Okay. We decided to allocate 10% of the bundle payment into the physician bonus model based on the AQC model. We also decided to use the patient quality and safety program of BCH and its 6 dimensions in order to implement the quality initiatives into the physician bonus model. This means that in order to win a bonus, physicians would have to not only contain costs, but would also have to remain within the quality standards. This physician bonus will be calculated by multiplying the total bonus distribution amount times the percentage of the PPSQ measures achieved. This then would be divided by the total number of physicians. The overall goal of our bonus payment, the bundle payment model is to increase quality, represented by the y-axis, and to decrease cost expenditures, represented by the x-axis. This means that we wish to improve quality as we also contain costs. The green portion that you see right here in the graph is the bonus achievement area, where physicians would not only stay within the quality standards, but also stay within the budget line. This bonus achievement area can be seen here in quadrant 2, where low cost and high quality would yield the best practices. These best practices are seen here by the blue symbols. The overall goal of this particular graph is to show our particular considerations in the chances that an unpreventable adverse event occurs. And this is represented by the yellow symbols that exceed the green budget line. The physicians that stay within the other quadrants, such as quadrant 3, would not receive a bonus. Next slide. In this part of our presentation, we will be going over our added value to the patient. By implementing strategies such as TDABC, SCAMPs, bundle payment, and other strategies, we will provide we'll increase access to Medicaid patients as we renew and also expand our Medicaid contracts. We will also increase quality to the patient because providers will compete based on quality and measures. This will also drive innovation because patients will have more timely care. Lastly, under post-service, this will include quality of life because it will increase emotional well-being, and we will also have less school and work days missed by the children and their parents. To demonstrate this added value to the patients, we shall implement strategies such as visual displays of PPSQ measures under BCH. We shall also implement technologies such as e-boards, and we shall also explain quality of care to patients. The overall goal of our bundle payment is to provide cost-effective, high-quality healthcare to BCH patients and their families. This will not only increase revenue for BCH, but will also expand our patient market. This concludes our presentation. Thank you, and we will not take any questions that you may have.
While you're standing there, this is for you, the physician bonus model. You have their total bonus distribution amount. How is this total distribution amount determined, or how should it be determined?
You mean the 10%? What do you mean?
Well, you have to have an amount to go from in order to spread that around, right?
Yes.
So how do you determine what you start with?
That amount? Okay. Well, it depends on the phase that we're in within our bundle payment. For example, if it's phase 1, it would be by individual treatment. So you would, can you go back? Well, if you have a particular treatment, then all the physicians that would would treat the patient under that treatment, then they would divide the bonus between them. If it's phase 2, it would be for an episode. And then under the third phase would be under global capitation. So it would be more of kind of like episode with chronic conditions and all of that.
And to add on to that, the total distribution amount, we took that from the AQC model that we researched, and 10% of the AQC model that's already implemented by Blue Cross Blue Shield, they use that exact percentage. So that's what we propose that BCH implement when determining. So it would be just 10% of the total bundle would be allocated for the physician bonus model.
Okay, thank you. Let me compliment you on your slides. Extremely well done, very thorough.
Thank you.
Very professional.
Thank you.
Ladies, I really enjoyed your presentation. Wonderful job.
Thank you.
Now, let me ask you a question from a cost perspective of implementing this methodology. I'm a hospital administrator. I look at something like this and I say, okay, how many FTEs is this going to cost me to implement this? And say I have I'm going to have 10 service lines. I'm going to have a service line administrator at 100,000. There's $1 million there. I'm going to have 2 analysts. It's probably $1.2 million to do the mapping, to work with the physicians, to do the analysis. This is a lot of work. I mean, I've done this in my career. It is a lot of work, very time consuming. And that's at a minimum. I'd say you're probably at 1.5 million when it's said and done. Do you think it's realistic?
Absolutely. I'd like to highlight our worksheet. Let's look at the different procedures here. One of the reasons why I think TDABC is effective is because it takes into account the complexity of the procedure. So if we have physicians that are spending 40 minutes on a craniosynostosis, but we're charging $350, but it's the same for a procedure where they only spend 18 minutes. I mean, we're losing money here. That's the point. In some areas, we're charging too much, and in some areas, we're not charging enough. Craniosynostosis, the charge is too low, so we're being reimbursed at a lower rate. So it is important because I think in the overall scheme, it will pay out. Like I stated earlier, it does require an initial investment to launch, like you said, that 1.5 million. But I think in the long term, it is more beneficial because it also helps us when we had talked about scamps and process flow and being able to really understand what our time is and how long it takes to provide a procedure. Maybe we can cut costs so that we do see a gain in revenue. And so it's a step-by-step incremental process. I completely agree with you. It does take an initial investment, but that investment will definitely pay off.
You think the cost savings from doing this will more than pay for the labor?
Yes. I would never argue that it'll happen in one year, one fiscal year, but in 5 to 10 years, I do see it. I think I understand your hesitation because TDABC hasn't been implemented in very many hospitals. BCH is the only one in Massachusetts, and it's coming from Porter, from Harvard. And I understand your hesitance, but we're seeing that the movement towards this not only increases our revenue and decreases our costs, but it's beneficial for just the way the entire hospital runs as an efficient level. So we're able to provide more population-based health.
I think we're running short on time, but I do want to say it was a very solid presentation. You hit every key point: strategic, financial, quality, value to patients and to BCH. So congratulations.
Thank you very much.